Hello, my name is Sander Koeter. I'm an orthopedic surgeon specialized in knee surgery from Nijmegen in the Netherlands. I feel very privileged to be asked to make this video on the results of our latest research. We conducted this research on the correlation between smoking and outcomes because I feel very committed to reducing unnecessary and preventable complications after joint replacement surgery. My father was a pulmonologist, thus very professionally involved in the consequences of smoking on health. A mission that I feel should not be limited to specific medical specialties, but a message that all doctors should bring forward to their patients. A message that is perhaps most easily conveyed on teachable moments, such as before elective or acute surgery. I present the results of an article called "Smoking is associated with a higher chance of revision and mortality following primary hip or knee arthroplasty surgery." This is a cohort study with a little over 2,700 patients from the Dutch arthroplasty registry, which we conducted with our Nijmegen research team, Joris Bongers, Maartje Belt and Katrijn Smulders, and with Anneke Spekenbrink and Wim Schreurs from the Dutch arthroplasty registry. So, what did we do exactly? We investigated the association between smoking status and the risk of revision and mortality within 2 years following hip or knee arthroplasty surgery with data from the LROE. Why did we do this? Well, smoking can be a predictor of poor outcome, and previous studies have reported smoking as a risk factor for periprosthetic joint infection, aseptic loosening, and revision. Smaller registry studies showed conflicting results regarding the effects of smoking on revision rates. Nicotine is a vasoconstrictor that reduces nutritional blood flow to the skin, resulting in impaired tissue healing. Nicotine also increases platelet adhesiveness, raising the risk of thrombomicrovascular occlusion and tissue ischemia. This is the data selection flowchart, which can be found in the article. We compared a little over 28,000 smokers with 244,000 non-smokers. There were thus a little over 10% reported smokers. We used hazard ratios adjusted for age and sex and found elevated risk of revision in both total hip and total knee arthroplasty surgery and an elevated risk of mortality in all groups. When analyzing in more detail, the smoking group had a higher risk for revision following total knee arthroplasty, but not following total hip arthroplasty. When looking at unicondylar knee arthroplasty, smokers had a higher risk of mortality, but no differences in risk of revision were observed. This study showed that the risk for revision and mortality is higher for smokers than for non-smokers in the first 2 years following total knee and total hip arthroplasty surgery. Smoking can contribute to complications following primary hip or knee arthroplasty. All the results of our study are depicted in this brilliant infographic from the LROE. When putting all these numbers in perspective, these findings do not implicate that smokers should be denied primary hip or knee arthroplasty, but smokers should be informed of the associated risks of revision and mortality. When looking at these results from a clinical perspective, we feel that patients must be advised to cease smoking before surgery because elective and acute surgery can be considered a teachable moment for patients. Thank you very much for your attention. Please find the original article on the Acta Orthopedica website or the open access article, which can be found using this QR code.